Hello, everyone, and welcome back to Luncheon with the Experts, a Carcinoid Cancer Foundation program brought to you by Ipsen Biopharmaceuticals. My name is Rain Bennett. I am your host this week and every week, and I'm a filmmaker and a writer that's been working with CCF for 10 years, a decade, in fact. Isn't that crazy? Super fulfilling part of my career. Love the work that we've done. As I said, I'm a filmmaker, so primarily that has been in the video content space. Sometimes live video series like the one you're going to watch today, and sometimes produce videos, sometimes documentaries about patients, all kinds of stories and information through video, but all with the same mission in mind, and that is to educate people and spread awareness about this disease, about neuroendocrine tumors, neuroendocrine cancer. That is what we are here to do. Every day, that is the mission of the foundation. So if you are new to that community and new to this community here at the show, I want to say welcome. And I want to encourage you. You might see the people in the comments section already doing that, saying hello. Look, we've got Brazil, Canada, UK in the house already. If you're new, Nepal, AJ, what's up? If you are new to the community, introduce yourself. They will embrace you. They will support you. They will help you. Okay. This show is twofold in terms of its value: information from experts and shared stories, shared experiences, and support from other people in the community, patients, support group givers, support group leaders, caregivers. Okay. Everybody in this community works to help each other. So lean into that, say hello. As you can see, everyone else that is used to being on the show is already saying hello. Dana from Marquez Cancer Center. So we've got someone on the home team here giving a little hat tip to our guest today. Before we get to our guest today, we always want to thank our sponsor, Ipsen Biopharmaceuticals. Look, folks, it's very simple. Without their support, we couldn't do the show. So we thank them every week, and we really, really appreciate their support. And we also like to include this disclaimer from them before we get started, and that is that the opinions expressed by our guest presenters, as well as the questions asked by you all, the audience at home, haven't been created or suggested by the sponsors of Luncheon with the Experts, and CCF doesn't endorse or promote any of the views, opinions, or information provided in this presentation. Audience members should not rely solely on the opinions or information expressed by the guest and should seek guidance and direction from their own medical advisors regarding any choices they make about their health or treatments. That last line is really the takeaway there, folks. We're going to give you some great general advice and some answers to your question, but we don't know your specific case. We can't answer very case-specific questions. So take these answers, take this general advice back to your home team that does know your specific case and make the best plan and path forward for you. Because if there's anything that I have learned over the past 10 years of working with CCF is each case of this disease is unique, and therefore each plan and path forward is as well. Okay, so go ahead and start sending in your questions. But before we take them, I want to take a moment to introduce our guest, who has been on the show multiple times, I think, or maybe in the predecessor of Luncheon with the Experts, but definitely been on Luncheon with the Experts before. He has become a friend of mine. I've worked with him several times. We're always excited to have him here. I can assure you this is going to be a great show, very thorough with his answers. It's not even fair to say a rising star anymore. I think the star has risen. Dr. Aman Chauhan, thank you again for being here.
Rain, you're very kind. Thank you so much for having me here. Thanks to Carcinoid Cancer Foundation, Grace Goldstein. And Grace, I want to say, I still have my Let's Talk About Nets coffee mugs, so everybody in the audience, whosoever is joining throughout the world, very grateful to have you all here. Please sit back, relax, grab your cup of chai, coffee, or bourbon, and let's enjoy an interactive Q&A about neuroendocrine tumors.
Now, folks, I talked with Dr. Chauhan briefly for a moment before we started, and there's a lot of exciting things that he's working on. We don't want to talk about it yet because I want to see your questions first, but he's working on a lot of exciting things in terms of potential treatments coming down the road. And these are things that I know are important to you because I get your questions every week. Okay. So I'm really excited about this show. Our numbers are jumping up already. So that shows me you are excited too. Now, if you're new, or even if you're a regular, a couple rules of the show, not rules, but just guidelines, right? We can't get to everybody's question. We get so many every week. So a couple things that you can do to help me help you, right? That's what we're here to do. Keep your questions general or generic in terms so that they still inform you for your situation. But if you start asking a super long question that is very, very case specific, and Dr. Chauhan is not your doctor, We just can't do that today because each case of this disease is unique. Okay. So ask some general questions. Go ahead and start sending them in. If we don't get to your question, you can always follow up with CCF. I encourage you to do so because our goal is to get you that information that you seek. Okay. If you know someone who would benefit from this show, from this interactive one-on-one session, tag them in the comments. Let's get as many people here as possible. The more people here, the better. Now we're going to have this show replay. It'll stay here on the Facebook page under the videos tab. And starting next week, we will put it on YouTube as well. And you'll get a lot of value from that. But the interactive session is really where you're going to get the most value. If there's something you've been struggling with, if you're at a place that is not a net specialty center, maybe your doctors aren't as familiar with it, you're going to get a lot of value out of this. So try to get your questions across. I'm going to do my best to get to them. Okay. But one thing you can do to help, or one thing that helps me understand which questions to get across for sure, is if you see a question that you're also interested in, right under the question, there's an option to like it. And if you hover over like with your cursor or your mouse, it'll give you a few emojis you can use. It doesn't matter to me. They all work the same way, but it tells me there's a demand for that question. If I see 8 people like that question, I know that that's a very important one to get across. It's not very case specific. It may help out 8 people with answering one question. So that's very important. So that's something that you can do to help me. And in the meantime, go ahead and start sending in your questions. Our numbers continue to rise. I see everybody saying hello. And again, I want to reiterate, if you are new to this disease and this community, I want to welcome you to the show. We're here every week. We have recorded so many of these episodes, I can't even remember. We've done this every week for a long, long time now. So use the database, the library that CCF has created. And they were creating videos before I came along, but since I've been here in the past 10 years with them, we've created a lot of content, okay? There is a lot of information that we have that can help you. So look through it. If you have a question we don't get to today, chances are we've made a video about it. Okay, Dr. Chauhan, let's talk a little bit about, as we get started, where you work. You know, I've worked with you there. I've filmed you there, and I know the staff that you have there. But tell me a little bit about why, Kentucky and the Marquis Cancer Center is one of those centers that really leads the way in terms of understanding this disease and how we can best approach it, diagnose it, treat it. What do you all have going on behind the scenes there that we need to know about?
Thank you, Rain. And that's a fantastic question. I have to attribute the success for Marquis Cancer Center neuroendocrine program to my guru and mentor, Dr. Lowell Anthony. When he moved from New Orleans, LSU, where I did my residency, he established the NET program here from scratch. And he had a wealth of knowledge, 30 years of his career experience in neuroendocrine cancers, which led him to develop a very sound program. We had then Dr. Ed Bolin join us. So I was very, honored and privileged to have 2 of the world's best, among the best mentors in that space, Dr. Bolin, Dr. Lowell Anthony.
Seriously.
And in last 8 years, we have moved from, just a NET program to a comprehensive NET research center where we are doing a lot of preclinical research. That means testing new agents, new drugs, new promising things in neuroendocrine tumor animal models. And if it looks promising, we are now switching them to, or flipping them over to early phase clinical trials, phase 2 trials. And we probably have among the most number of clinical trials in the NET space available as anywhere else. So numerous clinical trials, all phases for both low-grade NETs as well as high-grade neuroendocrine cancers. So what really makes our program unique is the people. Dana was here. She said hello. Hi, Dana. We have a fantastic group of staff, from our new patient coordinator, Joy Haney, to our PRRT coordinator, Dana, to our clinic nurses, both mine and Dr. Lowell Anthony's, Kara, and my nurse, Misty. They are just exceptional. We have a dedicated, pharmacist in our clinic, Danielle. So we work together as a very close-knit team, and our whole goal is to provide a very smooth experience to our patient. Besides this is just the med-onc front of it. As you know, neuroendocrine cancer is truly a multidisciplinary sort of disease, and we approach it that way. So we have very strong net surgeons, Dr. Kavnar, Dr. Kim, Dr. Pindali, three of them who focuses on NETs, and they meet us regularly during NET tumor boards. Besides that, we have NIH-trained nuclear physicists and radiation oncologist. Dr. Charles Munoz recently joined us from NCI. Dr. Riham El Kouli has been here, who does our nuclear medicine and a lot of our PRRT. So we truly have a very well-rounded program. Dr. Inavnet, who is very well known in the MEN circle, he's the chair of the surgery. So he does a lot of our endocrine surgery. So it's one-stop shop for anything NETs, from clinical trials to standard management. And I'm very happy and very proud of what Marquee NET Clinic has done or achieved in the last 8 to 9 years.
As you should be. And it's apparent that the community there is strong, because I've seen several people that are tuning in from your cancer center that are saying hello. And if I started listing their names off, we'd probably be here for the whole hour. But I love to see that support. And I love to also see, folks, how far this program reaches. We've already talked about this. There's a lot of international people attending today. That's typical, but I've seen a lot. I see our friend Ursula from South Africa, Shelly from Ottawa, Canada. And Shelly, just real quick, the first work I ever did for CCF was at a NETS conference in Ottawa long time ago, 2011, 2012. And then also real quick, Rhonda from Zebulon, North Carolina. Rhonda, I'm in Durham. So we're practically neighbors. All right. So Dr. Chauhan, we have questions coming in and we need to get to them. First question, we have a few right here about the Y90 procedure. Okay. Or a couple at least that I see. Richard says, I had the Y90 procedure a year ago, which had a little success reducing some liver metastases by about 25%. And the question is, can Y90 be used a second time? Because we're starting to see some minor growth again. And let's start off, Dr. Chauhan. Let's pretend we have, people that are new to this. Let's explain exactly what Y90 is before we proceed with the answer.
That's a great question. Thanks, Rain. So neuroendocrine tumor, one of the areas which likes to attract neuroendocrine tumors or get seeded with neuroendocrine tumors is liver. Of course, that's not the only place. That can metastasize to bones, lymph nodes, and various other. But by far, the commonest area where it likes to go when it spreads is liver. And if the disease is primarily located in liver, what we call liver dominant disease, so there's no disease outside liver, then there are approaches where we can just target towards liver-directed therapies like embolization. So we try to avoid systemic exposure of a drug, be it an IV drug or a pill, because if the disease is primarily located in liver, can we do something local regionally, like resection, take the tumor out, or embolize it? That means we destroy the tumor by going through the veins or the blood vessels and try to target it. Now, how we do that? There are primarily 3 ways to do that. One is called bland embolization, where we try to choke off the blood supply to that tumor in the liver. So we do it with these beads, which basically plugs the blood supply to the tumor. And without the blood supply, any living tissue would die. And that's how we target the cancer. Yep. The other way to do is TACE, where is a chemoembolization. So these beads not only reduce the blood supply, but also are releasing chemotherapy locally in that area. So there's a double damage, the ischemic damage to the cancer, and on top of that, the chemotherapy tries to kill some cancer cells. And the third way to do embolization is radioembolization, and where this question kind of comes in. Right. So here we try to embolize the beads which are radioactive, Y90 to be precise. So yttrium-90. So these beads don't necessarily completely choke off the blood supply, However, they do go and they are released in the area in the liver where the tumor is. And as you know, the radiation that does the heavy lifting, the radiation from the Y90 would cause the DNA damage in the living tissue around, hopefully just the tumor. And over the period of days to weeks, this tumor would then start dying because of the radiation-based DNA damage in the tumor and would start shrinking. Now, the question, and these three are legitimate approaches, the bland embolization, the chemoembolization, or the radioembolization to target liver-dominant disease in neuroendocrine tumor. We don't know one works better than others. There is no head-to-head. There are some trials going to look into if one approach is better than other. Having said that, you are also aware of a new FDA-approved drug, or recently FDA-approved drug called Lutathera, which is another radiation-based treatment, and it works quite well. That's what led to its FDA approval. We'll probably talk a little bit more about it later in the conversation. So we live in the era of PRRT, where at some point in time, most neuroendocrine tumor patients will get PRRT sooner or later for metastatic disease which have somatostatin receptors. Now, in that era, if we are going to subject patient to a radiation-based treatment, I try to avoid Y90-based treatment at our center, and that has been our institutional sort of preference for now 3 to 4 years. This is also consistent with a lot of my other friends that at big net centers. They are preferring not to go down the Y90 route. Not saying that it cannot be done. We just have to be cognizant of the added radiation risk. So what happens with Y90, there would be some normal liver which will get exposed to radiation. I have seen patients in past who've developed cirrhosis long-term after the Y90 treatment. So when we know we have a drug like PRRT, which we will be using at some point in time, I want to minimize the exposure to normal liver to radiation. So in our practice, we do not do Y90. Having said that, so to answer this gentleman's question, I would probably recommend not doing a repeat Y90. Again, this is consistent with what we are doing. We don't even do it the first go, and maybe explore other ways to target the liver dominant disease. And we have bland embolization, TACE, and other, and so in certain cases, even surgical resection. So kindly review those options with your provider.
Awesome. Thank you. And I appreciate you laying down that foundation as well. That's super helpful moving forward, I think. Next question from Janace, our friend who has become quite the regular. I see your name every week, it seems like. Having H/O carcinoid syndrome events and crisis. Starting PRRT next week, what are the chances of syndrome event and when might it occur, if so?
Right. That's a fantastic question. There is a theoretical risk. However, it is very, very rare. At our own center, we have now done over 150 PRRT treatments, and we have rarely witnessed that. That is also consistent with what we are seeing out in the community, or at least in published literature. However, theoretically, yes, any event which leads to cancer cells dying, be it with the chemotherapy or radiation or Lutathera in this case, and the patient has very high serotonin to begin with. These are the tumors which are pumping a lot of serotonin, and you cause tumor lysis, and tumor cells are dying and spilling all that serotonin into the bloodstream. You can theoretically have a carcinoid crisis. So if the baseline serotonin is very high, patient already has an uncontrolled carcinoid syndrome, a lot of flushing, a lot of diarrhea. These are the patients which we also like to try our best with the help of our systemic agents, be it lanreotide and other agents, to control the serotonin as well as best as possible, and just be cognizant of that immediately after PRRT, if somebody has a lot of flushing, a lot of diarrhea, things are going back, that they have rescue short-acting somatostatin analogs, of course, and bring it to their provider's attention if they are feeling particularly sick in the first few days after the PRRT. Having said that, it is highly unlikely that somebody's going to get into carcinoid crisis after PRRT. Highly, highly unlikely. In fact, on the contrary, we have now data from NETTER-1 which suggests that that Lutathera or PRRT not only helps stabilize the disease, but also improves the quality of life, limiting diarrhea. And we have seen some subgroup analysis from NETTER-1 studies showing much improvement in the diarrhea and the quality of life and energy and fatigue and all those things after PRRT.
Got it. Thank you. And thanks, Shanace. And for those at home, just to clarify, the abbreviation H/O is just history of. When I read these questions, it's often like a news anchor who's just reading the teleprompter, and then afterwards you can oh, never mind, I know what that is. So just to clarify,
that is our medical lingo.
Exactly. There's always an acronym, right? Okay. From Jem, what potential future, this is kind of still in the same space, what potential future treatment options are currently being explored specifically for patients without the presence of receptors? We get this question a lot. For whom PRRT and Y90 embolization are not viable options?
Great question. And there are a lot of options these days, and many of them are under investigation. So we have access to them through clinical trials. So if somebody is receptor negative, that means they don't have somatostatin receptors, and we really need those for PRRT to work, because PRRT is basically a radio-labeled drug which likes to go and bind to somatostatin receptors.
Right.
So if there are no receptors, we don't have the targets, right? But having said that, based on which disease we are treating, now NETs is like a bouquet of diseases. There are low-grade NETs, there are high-grade NETs. There are well-differentiated NETs, and then there are poorly differentiated neuroendocrine carcinomas. So based on what we are dealing with, we can stratify the treatment. So if I have a low-grade NET patient, or well-differentiated NET patients, but happen to have very low receptors or no receptors, like the scenario presented here, we still have options to treat with mTOR inhibitor, Afinitor. If it's a pancreatic NET, we can try the TKIs like Sutent, sunitinib. There is a clinical trial with cabozantinib, and the phase 2 data from cabozantinib was very promising. And the study is now in a phase 3 setting. We have that open here, and various other centers throughout the country have the cabozantinib study open. Besides that, there are other agents under investigation. Surufatinib would be one, and it is, I think, available as an expanded access at certain sites. The data from the registrational trial so far looks promising. I think MD Anderson had the study open, and they presented some of the US subgroup of the data that looks promising. So a lot of drugs are available based on what we are treating. Now, of course, we are treating high-grade, poorly differentiated neuroendocrine carcinoma, then it's a completely different ball game. And we often use immunotherapy or chemotherapy or a mix of those. But yeah, it does look very promising that there are some other agents. We ourselves are, besides all these options that I've mentioned, we are looking into immunotherapy or role of immunotherapy. Traditionally, immunotherapy hasn't panned out in the well-differentiated low-grade NETs, but that, that really, makes us investigate immunotherapy in different forms or combinations to, can we make these low immunogenic tumors respond to these immunotherapies. So right after this meeting, we are hosting a site initiation visit for an oncolytic virus therapy, which I can use in various cancers, including neuroendocrine tumors. So there's a whole lot happening, and we have a lot more options besides just the Y90 or, like this, the gentleman mentioned, PRRT.
Absolutely. Folks, if you just joined us or joined us a little bit late, this is Luncheon with the Experts, a Carcinoid Cancer Foundation program. We're here today the University of Kentucky's Dr. Aman Chauhan, who's been on the show before and is an incredible guest, an incredible bright mind in the net field. We often talk about some of these, I don't know if you want to call them titans of the net community. You know, we've alluded to a couple. You, Dr. Wolin, you mentioned Dr. Anthony, you know, two of your mentors. And personally, I think Dr. Chauhan, you're that next group that's coming up. I mean, I just am so appreciative and grateful for all the work that you're doing. We always love to have you on the show. A lot of great questions, folks, so far, and a lot of great answers from our guest. We're going to keep it moving. Next question from Cynthia. Cynthia says, I see, this is a good question. I see lots of people after surgery continue to take lanreotide for many years, hoping to control the disease, even with no detectable metastases. And then some don't. So how do you decide whether you're going to continue to take lanreotide for a long time after surgery or not?
Wonderful question. And we don't know the right answer yet, because there's no trial which has been conducted post-operative situation. We call this situation as adjuvant therapy. So, for example, patient has tumor, and hopefully the tumor was in relatively early stage or was resectable. Okay, so the surgeon went in and took the tumor out. Now there is no visible disease left on the scans. The question is, should we continue the lanreotide or sandostatin for that matter? And the idea to do that would be to maybe delay the relapse or prevent the relapse, right? So there is no study which has been done where half the patients after the surgery got lanreotide and other half just the observation, and one arm did better than others. So with that caveat, without knowing the data, this is our practice, and some of my friends who are net experts at other leading sites also sort of do the same. If we do not have measurable disease, once patient has been operated and there is nothing that I can see on the scans, then I hold off on continuing any therapy. Because you have to understand, anytime we continue the therapy, the way we note the effectiveness of therapy, whether the therapy is doing anything or not, is by watching the scans. And that's why we do these scans, right? So if I have no disease to target, we call them target lesion. If I have nothing to track the effectiveness of the therapy, then I don't know whether I'm just giving this medicines for a theoretical improvement or benefit, or is it really doing anything? And we also know all the treatments or all the intervention has financial costs and toxicities, and just the fact that patient has to come for a monthly shot, right? So these drugs, lanreotide and sandostatin, these are fantastic drugs, right? These forms the backbone of the treatment for metastatic NET patients. But that doesn't mean that everybody needs to be on that. So if after the surgical debulking, as it's nothing measurable, I try to hold off on continuing it till I have something visible on the scan that needs to be treated. Now, having said that, there is a small caveat to that. Some of the patients, so one of the reasons why we do these long-acting somatostatin analog like lanreotide is to control the disease. They are fantastic in holding the tumor growth. That is one of the reasons. The second reason is that they also help with carcinoid syndrome symptoms, because a minority of patients would secrete these hormones, for example, serotonin, and that gives some symptoms. And the concentration of these symptoms together are called carcinoid syndrome. These could be flushing, diarrhea, wheezing, muscle aches, a lot of these things, okay? Now, if there is no visible disease, but patient clearly has carcinoid syndrome, and we confirm it with some blood tests or urine 5-HIA, and the hormone levels elevated, then in that particular scenario, it would make sense to alleviate these symptoms to help improve the quality of life, that we will continue the hormone shots. However, it sounds highly unlikely. If we are not seeing anything on the scan, then where is the hormone coming from? So it sounds unlikely, but that would be one scenario where I would continue these shots after the surgery even if I can't see anything on the scans.
Gotcha. Thank you. Thank you very much. Next question from Julie. Hi, I have a renal cell carcinoma and 3 liver nets. Would a net surgeon be likely to be able to remove the renal tumor during liver net removal if that was viable? I'm waiting for my net specialist appointment.
Great question. I personally, if I need 2 different surgeries or 2 different things, I like to club them and make it easy for patients. At our centers, we do this all the time. So somebody needs a debulking surgery and at the same time also needed a hernia repair. You know, our surgeons, they like to tag team it. We bring in a hernia specialist, and we bring in the net specialist, and they do their own things. That is really helpful for the patient because you save them one additional procedure, and during the same OR time, you don't have to go through this twice. Now, having said that, and I'm not a surgeon, you know that, right? So this might not be applicable for all the procedures. Sometimes, there are certain procedure might be too invasive, too involved, and you want to just schedule a procedure for a particular surgery only. So definitely talk to your surgeon and see what can be clubbed together in one setting, and that I think we should certainly be explored. And usually surgeons are welcoming of that idea. They want what's best for the patient. And if they can save them one additional procedure and can be done in one setting, then they certainly should strive for that.
Got it. Thank you. From Brian, if TACE, TACE, which I do know this acronym is transarterial chemoembolization.
Wow,
right?
Rain, I need to give you an honorary doctorate.
Yes, you do. I looked it up, folks. I'm not going to lie. If TACE for liver metastasis is working and controlling at 3 to 5 year intervals, I've had 2. Do you expect PRRT potentially in the future as well?
Yes.
Let me know if you want me to repeat anything.
Yeah. So if the TACE has been working well, and it's been significant time period, 3 to 5 years, can we still get the PRRT in future? Yes. I consider metastatic nets like a marathon, right? As of now, we don't have curative treatments. We cannot completely get rid of it. We are trying hard, and hopefully in my lifetime, we find a cure. But as of now, it is not a curable disease. So we tried to make it a chronic disease. It is a chronic disease, chronic manageable disease, like diabetes or high blood pressure, right? So we try to control it as long as possible. The better job we do in controlling it, the longer the patient lives, the better the quality of life. And those are our 2 guiding principles. If we cannot get rid of the disease, we try to slow it down and we try to improve the quality of life of the patients, right? So at some point at the time, most NET patients, including this particular scenario, would qualify for PRRT, for that matter, Afinitor, for that matter, other systemic agents, right? No single drug's going to completely eradicate the tumor. So it is a marathon. How we sequence that is a big unknown. And it's a big hot topic in our field. So, and there are a lot of factors which go in helping us pick and choose, should PRRT come first or should we embolize first and go from there. Again, one of the critical thing here would be if it's a liver dominant disease and there is no disease outside liver, there are effective therapies that we can do like embolization to control that. And we can save the patient drugs which have more systemic action. So it works not only in the liver, but also outside. PRRT is also a limited time drug. So you cannot do it indefinitely. So you have at first go, you can give up to 4 rounds, and then there's some data to support that you can repeat the limited rounds of PRRT at progression. Having said that, you cannot just indefinitely do it because of radiation excess and exposure and long-term side effects. So you have to be cognizant of that, be judicious in the use of the treatments that you're doing, and sequence them. So if you can stabilize the disease with embolization or surgery or ablation or local regional therapy, please do that and save systemic therapy. But there might be a scenario where these surgical options are not possible for certain anatomic reasons or patient preference or There is extrahepatic disease as well. So not only tumors in the liver, but outside the liver, PRRT can be a great option for those patients. That's why these things need to be discussed with the provider and also hopefully in a multidisciplinary tumor board setting.
Got it. Got it. Thank you so much. All right, moving on from Becca. Kind of a common question with a little bit more specificity. How hereditary are neuroendocrine tumors? It seems like even when people are negative when getting genetic tests for things like MEN1, MEN2, they may still have multiple people in their family with NETs. Is this just random chance?
Yes. So having multiple family members with different NETs does raise a red flag that could there be a genetic mutation which is predisposing. But usually the genetic tests that are done these days are highly accurate. And when I talk about the genetic tests, these are tests done in germline to check for germline mutation. So to miss that is highly unlikely because all the healthy cells in the body, and I don't know what type of test they did. Sometimes you have buccal swab. So inside your mouth, they take some, mucus cells and have some DNA and you run the test. Or sometimes more commonly, we do blood-based tests. But we are not looking for tumor cells. We are looking for normal healthy cells and the normal genome and looking for these mutations that. So the chances that these germline mutation tests are negative or false negative, very, very low. But if there are concerns, can also certainly be repeated. However, if a germline test is negative, I'd probably be a little bit reassured that, okay, we are probably not dealing with well-defined genetic disorders which put you at a higher risk because those have a different recipe. You have to follow certain labs, certain imaging, and all those things that goes with the surveillance of those. But here it is a little bit unique situation. It seems like multiple family histories, but personally, the patient looks like have been evaluated. So I would tell the patient, keep an eye out on if you have any new symptoms, bring it to your doctor's attention, but I would not be overtly worried thinking that you can develop NETs if your personal germline mutation testing is negative. If you are concerned about the quality of tests and there was an issue in the way the test was done or the sample might have gotten bad, you can always consider repeating it. Please discuss with your oncologist.
Got it. Thank you. Next question from Andrea. Is it common for a grade 2 PNET to mutate to a grade 3?
I won't say it's common, but I would say that it can happen. And that holds true for grade 1 turning to grade 2 or grade 2 turning to grade 3. All it means is that as the tumor progresses under the stressors of the growth and the anti-tumor agents that we are trying to use to fight against the cancer, the survivor cells or the cancer clones, which end up surviving all our onslaught with the medication, they tend to be a little bit more aggressive. And sometimes that aggressive behavior shows in the way that they are a little bit higher grade tumors. Mm-hmm. Sometimes they could be just more aggressive, but same grade tumor, they're just resistant to our previous therapies. But yes, the short answer, it can happen. I've seen that happen. I think we are recognizing this more and more.
Got it. A PRRT question again, but this pertaining to lung nets. Is PRRT recommended for primary lung nets with bone metastases? Is typical carcinoid grade 1?
Yes, so it works. I think if the tumor has somatostatin receptor, it doesn't matter if it's lung or it's stomach or it's pancreas. The concept is same. However, there are these nuances. NETTER-1 study, which led to FDA approval, was done in mid-gut NET patient population. Luckily, FDA was little generous, and I'm glad that they when they gave the approval, they included GAP NETs, so mid-gut and pancreatic NETs. Unfortunately, for our lung net patients, the lung nets were not included because it wasn't formally studied in the clinical trial. So that raises this question, can we do PRRT in lung nets? Just because it wasn't studied, I personally believe that if the patient has targets, when you do the copper scan or the gallium dotate scan, and it's a very somatostatin receptor avid disease, it should work. There are some clinical trials looking at this subpopulation. However, if there is no access to the Lutathera or PRRT agent, it should work. The important question here is, unlike GAP-NETs, there are quite a few lung net patients who don't tend to have high receptor expression. This percentage is a little bit higher than the GI nets. So most GI low-grade grade 1 nets would have somatostatin, very high somatostatin receptor expression, but some lung nets tend to not have as high receptor expression. This is especially true for atypical carcinoids of the lung, okay? So it is very important to get the somatostatin receptor PET scan, and it's both are equivalent, the copper 68 or copper 64 or gallium 68, and then review what is the degree of the expression. Now, if you have very somatostatin receptor positive disease, I believe that the patient should benefit from PRRT and can benefit from the PRRT. Now, the access to the PRRT is an issue. We haven't had problems with treating lung net patients with Lutathera so far, touch wood. We haven't got pushback from the insurance regarding that. Again, the principle is it is a neuroendocrine tumor and has somatostatin receptors, so the drug should work. But the nuance is the FDA labels only for GAP-NETs.
Got it. From Ursula, many patients have their lanreotide sandostatin injections with PRRT treatment. Is there a reason why all patients would not be on both treatments? I've had large liver tumors, completed 5 rounds of PRRT in 2021, progressive growth from chemo, and then stopped treatment and started PRRT.
Right. Great question. So the way NETTER-1 clinical trial was done, and again, the reason I keep bringing back the NETTER-1, that's the largest prospective study which studied PRRT in the cleanest way, and it was an international multi-center study. So this is the best data we have, right, when we come to PRRT. And there, when they did the PRRT, they did continue somatostatin analog, but it was done intermittently during the PRRT. The idea behind that was, theoretically, you want to minimize the competition to the somatostatin receptors, right? So you have the PRRT drug Lutathera trying to go and join to somatostatin receptors and attack the cancer. At the same time, you don't want to give them the somatostatin analog. And this was sort of a theoretical concern. But the trial did continue the somatostatin analog intermittently. It wasn't done monthly like we routinely do, but intermittently. So you made sure that there was a 6-gap window before you're due for PRRT. You don't want to give them sandostatin at that time. So having said that, our practice pattern here is that we like to continue the somatostatin analog, be it lanreotide or sandostatin. I don't differentiate between the two. And after the PRRT is done, should we continue these monthly shots? That's a big unknown. We don't know the data yet. I am in my practice, based on our experience, I like to continue it, but we leave the decision up to the patient. Some patients would want to get a little break from monthly shots, and that's completely fair. Some patients would like to continue the shots and they don't mind. At the end of the day, we don't really have data. Patients who continue the shots after the PRRT or those who stop early, is there any meaningful difference in terms of how well the disease was controlled with just PRRT alone? And that is yet to be investigated. But till we have that data, I'm leaning more towards that unless patient has a reservation or there is issues with continuing somatostatin analog, I try to continue that on a monthly basis. Now, small footnote there, if patient has carcinoid syndrome, there is no question about it. Patient needs to continue on the shots to control the syndrome.
Got it. So Patty says, if based on a gallium-68 scan, a person has receptors, but they are not that bright, could they ever in time gain more brightness to make PRRT an option in the future?
That's a good question. So far, we don't really have well-studied approaches which can upregulate somatostatin receptor expression. Some of the, in our scientific community, some of our members are working on that hypothesis. Dr. Chen at Alabama, I know a big part of his research is how to get these upregulate these somatostatin receptors. So they are studying some drugs which can help bring this receptor expression up. But this is in very, very experimental stage in the lab. So it's not even in the clinical trial phase yet. So we are trying, but as of now, I can't say that any particular drugs that we know of or we commonly use in clinic can make the somatostatin receptors more prevalent or these scans more data avid. We have to fall back on other agents. If there's not enough somatostatin receptors, maybe PRRT is not the best choice. But as I mentioned before, there are other up and coming drugs that are looking promising, so should explore those options.
Got it. From Andrea, is PRRT an option after a full liver Y90 treatment? Patient does have cirrhotic changes in the liver.
This is one of the issues that we are shying away from using Y90. Mm-hmm. Because Y90, and I have seen this issue several years after Y90 treatment. However, having said that, we have to be very cautious. We should evaluate how healthy the liver is, what is the baseline liver functions, and can the patient tolerate PRRT? There is certainly theoretical risk that patient can have liver damage, and that's why we try not to treat patients with PRRT who has abnormal liver functions, right? In the clinical trials, all the patients had normal liver functions. Having said that, we also have to deal with the real life situation, right? So in real life, the patients don't always have normal kidney function, normal liver function, normal blood counts, and that's the reality. And so we have to address these individual risk-benefit profiles with the patient. Now, if this particular patient has very high degree of cirrhosis, the baseline liver enzymes, bilirubin, are markedly elevated, I would be very cautious and very nervous about treating with PRRT. We also have to look into, are there any other available treatment options in terms of either clinical trial or other therapy options, mTOR inhibitor, TKIs, and other agents that can potentially be tried, sometimes even chemotherapeutic agents, right, to avoid the radiation-based damage. So again, it depends on what are our options and the baseline liver functions. Now, if we have no option left, and we know PRRT works great, but there is a risk of liver damage, then we have to bite the bullet and say, hey, listen, in the short term, we are going to get in trouble with the tumor growth and progression and liver failure from that standpoint. So the patient might opt to do PRRT knowing that, yes, they are at higher risk for further liver cirrhosis or damage to liver because they already had a baseline cirrhosis. Now, many patients have cirrhosis or cirrhotic disease, either because from NASH or, from obesity or chronic hepatitis C or alcohol. So that just the word cirrhosis doesn't automatically makes patients ineligible. So you have to be really careful about that. I don't want to scare people away, just because they have cirrhosis. Many people have fatty liver disease, right. And this is a global issue, and then have cirrhosis as well. So it depends on the degree of cirrhosis. At some places, we also do elastoscan, which is a fancy ultrasound, which can give us a little bit more detail about the degree of cirrhosis. And talking to a hepatologist and gastroenterologist would not hurt. So we often send patients to a hepatologist or GI specialist who has expertise in evaluating cirrhosis if we are worried can the patient tolerate PRRT or not.
Got it. From Teresa, can you speak more about the copper scans versus the gallium-68 scans? In other words, if you've had the gallium-68 scans all along and then you've had a copper-64, are the test findings comparable from one to the other?
Yes, great question. And to be honest, at a very broad level, they're equivalent. Okay, and I would not differentiate between the two. Now, if I'm a nuclear physician, nuclear medicine doc, or the technician at very, fine level, yes, there are differences, and you need to have the appropriate machines to harness the most sensitivity, specificity out of them. So I've heard that if you use copper scan in the old CT machines, then you can have some issues with the quality of imaging and vice versa. But in an appropriately protocolized scan, the images are equivalent and equivalent to to an extent where practically it does not make difference to the provider in helping us either monitor the disease or change the management. So the difference is negligible. So it boils down to the access issues. Many places are flipping to the copper scan because of the longer half-life. So the access to the drug, the copper-64, the talk, is easily available because it can be shipped centrally and distributed throughout the country. Whereas the gallium-68 dotatate scan, because of shorter half-life, has to be generated in the near vicinity. For example, our generators are in Cincinnati and they cater to us. So there is that scheduling issue and, coordinating with the PET scanner and all that, because the droves can go to waste if it's not well timed. So because of the logistics, I think many places are flipping over. At our place, we have done a lot of gallium-68 dotatate scan. In fact, we last year or a year before that, we published first 200 cases. Now I think we have done over 800 gallium-68 dotatate scans. So a lot of it, as you can see, but we also have access to copper-64. So really for me, practically no difference. It's really up to the center, whatever they prefer. It's not worth kind of fighting over that one's better or the.
Gotcha. Linda has a question that I've heard this in a variety of ways before. Can you have well-differentiated tumors and non-differentiated tumors or poorly differentiated tumors? Also, can well change to non-differentiated or poorly differentiated?
Right. Great question. And mixed tumors can happen.
Okay.
And there is an entity called mixed MINEN, mixed neuroendocrine, non-neuroendocrine neoplasia. However, when we do see mixed, we often see a totally different type of cancer, like an adenocarcinoma or a squamous cell cancer mixed with either low-grade NET or a poorly differentiated neuroendocrine carcinoma. Very rarely I have seen a poorly differentiated neuroendocrine carcinoma with a well-differentiated NET. So just like the scenario provided here, that can also happen. Whenever that happens, my approach is to target the high grade or more aggressive biology. So you have to focus and your initial priority has to be in managing the more aggressive cancer, because that's the one which will get us in trouble. So the high grade or poorly differentiated neuroendocrine cancer, that we will develop our treatment strategy for that. Now, what happens sometimes that your treatments for this high grade work so well that those tumors either die off, and then subsequently the residual disease is the low grade time. And then in those particular situations, you might have to switch gears and then target those well-differentiated NETs. But yes, it can happen. Now, the second part of the question, is it the well-differentiated neuroendocrine tumor that converts into poorly differentiated, or did they begin in distinct ways to begin with? Like they always started off with well differentiated and poorly differentiated. I honestly don't have a good answer for that. That probably needs a little bit more research.
Sure.
I know, and this is based on some publications from Memorial Sloan Kettering, where they did biopsies on patients anytime they progressed, and they did show that tumors over time can get more aggressive, so the grade can change. So it can, grade 2 patient can become grade 3 in future. However, I'm not sure if a well-differentiated can become poorly differentiated, or has that been described thoroughly in the literature. It is possible when the tumor becomes so aggressive and loses its characteristics of being well-differentiated and attains or acquires certain mutations which make it poorly differentiated. It can happen theoretically, but I just don't have a good answer right now for you.
I understand. Dr. Chauhan, we've got about 5 minutes left. I wanted to save some time for you to tell us a little bit about the trials that you're currently working on. I know we've alluded to research and that sort of stuff, and we've talked a lot about PRRT today, but you and I chatted a little bit before, and you're really working on some interesting stuff. And we still got a lot of questions, so we won't get to them all, but I just think this is really valuable for folks, and you've just got a few minutes. But can you tell us a little bit about those new trials that you're currently working on?
Thanks, Rain. And time is flying off. I
know.
Believe it. All right. I know. So one of the reasons why I wanted to come here is to develop new treatments. And I know it sounds tough, but I'm eternally optimistic. I think in my lifetime, we want to find a cure for this. And the pathway to that cure is clinical trials. Our current FDA-approved therapies have taken us is a big step forward, and we have come a long way from where we were just even 10 years back.
Yeah.
But we have to constantly improve on the current standard of care. So there are 3 clinical trials that I'm very, very excited about, and hopefully that they will help us take the next big leap. So I'm doing a lot of PRRT clinical trials, and one of the trials involves a pill called triapine, that we are adding to Lutathera. And the idea is that triapine would enhance the effect of Lutathera. So it'll be a fantastic radiation sensitizer and would help us shrink the tumor more, would help us to keep the disease stable for much longer. We presented our mouse model data at Boston NANETS, and it looks very promising. And we are the lead site. This study is open at various institutions, Moffitt, Mayo Clinic, City of Hope, and we are the lead site for that. Similarly, on the same lines, we are also now testing a very brand new cutting edge drug called peposertib, which is a DNA PK inhibitor, and we are adding that to Lutathera. And this is based on our preclinical data, looks very promising. Again, this study is going to be open at various sites. As of now, it's already open here, City of Hope, Ohio State, but many other sites would join us. Again, Markey Cancer Center is the lead site. We developed this study. And lastly, I would like to mention, we also have a pediatric NET study called NETTER-P. I think 4 or 5 sites in the US have access to this study. I would really appreciate if your audience can spread the word about pediatric NET program here, because this is a disease type where we have 0 FDA-approved treatments. And if this study is positive, might lead to its first treatment. So for the right patient, it might be a big boon. And the study covers for travel costs, logistics, and lodging for the patients, including the treatments. So those are the key ones. Of course, I cannot go on and do 20 different trials that we have here, but thank you, Rain, for the opportunity.
Absolutely. And I really wanted you I wanted you to mention them all, but especially the pediatric one, because as you said, you didn't really have treatment options for that. So this is really important. They're all very important, but we've talked the past couple of weeks about pediatric NETs. And so I think I'm excited to hear more about that, and I appreciate all the work that you all are doing there. And folks, that is our hour. That is the time. That is our show. Sonia says, thank you for a most informative session today. And Linda says,
Thank you.
great explanations. And then now all the heart emojis and support and appreciation are flooding in right now. We'll send you all those comments later. But thank you, Dr. Chauhan, as always. I really appreciate being here. You're so thoughtful. You're so thorough in your responses. It's really valuable every time we talk to you. So thank you for being on the show again.
Thank you, Rain. Thanks, everybody. Have a wonderful day, guys.
Absolutely. And thanks again to you at home. As always, we hope this program helped answer some of your questions. And as always, if you have follow-up questions, I encourage you to reach out to CCF either here on the Facebook page or at carcinoid.org. Thank you to our presenting sponsor, Ipsen Biopharmaceuticals. We could not do the show without them. And finally, my name is Rain Bennett. I have been your host. Thank you for watching, and please join us next time on Luncheon with the Experts. Stay healthy, stay safe, everybody. Bye-bye.